Welcome to all our viewers this evening. On behalf of Roanoke College, I welcome each of you to the series NOKELive from Washington, D.C. It's Healthcare Night. My name is Brian Parsons, and I'm Associate Professor of Political Science and the Chair of the Public Affairs Department. One of our co-hosts this evening is my colleague, Dr. Shannon Anderson, who is Associate Professor of Sociology and the coordinator of the Public Health Studies program here at Roanoke. This event is co-sponsored by the Office of Alumni and Family Relations, the Public Health Studies program, and the Public Affairs Department. Before we get started, please know that each of you viewing via YouTube can use the chat feature to ask questions of our presenter. Once the presentation is complete, Dr. Anderson and I will select and ask as many of your questions as possible. Tonight's event is being recorded and will be available on this YouTube channel for future viewing. A link to our past live events, as well as other online content, can be found on the Alumni Hub at roanoke.edu/alumni. This evening's NOKELive topic is Healthcare on the Hill. We're joined by Dr. Rodney Whitlock, a Roanoke College graduate in the class of 1987. Rodney has over 25 years of experience on the Hill, during which he served as former U.S. Representative Charlie Norwood's Health Policy Director, where he managed the Patient's Bill of Rights, among other notable health policy matters. Rodney then went on to serve U.S. Senator Chuck Grassley. He first joined the Senate Finance Committee staff as a health policy advisor to Chairman Grassley, and ultimately joined the senator's personal office as health policy director. During his time in the Senate, Rodney served as the lead Republican staffer for Medicaid legislation from 2005 to 2010, and continued to serve Senator Grassley on all health-related issues through 2015. Rodney worked with Republicans in the Senate on such prominent and important legislation as the Deficit Reduction Act of 2005, the Tax Relief and Healthcare Act of 2006, the CHIP Reauthorization Acts, and the Affordable Care Act of 2010. For the last 20 years, Rodney has been an adjunct faculty member in George Washington University's Milken Institute School of Public Health and the Graduate School of Political Management. It is now my pleasure to turn it over to Dr. Rodney Whitlock to begin tonight's presentation.
Thank you. And of all of the things that you said about me there, the one I actually appreciate the most is being called a Roanoke alum. And that's why I'm here tonight. And my thought in this and what we produced here for you all is a series where coming from Salem, which is where I'm from, Roanoke, which is over my shoulder here, and the opportunity to be able to give back to the college. This is something I've talked about for a long time. And the opportunity to at least maybe one of the incredibly small silver linings of our current life is seeing how you could do something in this Zoom type format remotely that allows me to bring what I've learned in Washington back home to my alma mater and students now in the political science or public affairs program and in the new public health program as well, to learn a bit about healthcare in Washington, D.C., and I'm doing so by bringing along some of my friends. And so that's the goal of the series. Well, this is the opener, so you'll have to tell us what you think and how well we did to start with. But hopefully we'll bring some guests to you throughout the school year to give you a taste of what it's like to be doing healthcare in Washington and particularly the politics, the policy, all of the fun stuff with that, so you can see maybe what could happen if this is something in your future. Tonight, I'm bringing one of my friends to the conversation, Seth Gold. Seth Gold is an alumni of George Washington University when in the Master of Public Health program. He previously worked in the House of Representatives for Dr. Michael Burgess before joining the United States Senate and the staff of Senator Rob Portman of Ohio. And so that's my friend Seth's background. But we'll open our conversation tonight, and we'll be doing this effectively in 4 parts for you. We'll start talking about some public health issues, the health side. We'll talk about the dirty, nasty politics of what it's like to be in DC. We'll talk about some of the pathways that our guests and how they got to where they are, and then we'll open up to questions for you. So to start, first of all, in the conversation, Seth, talk about what it is to be your current job, which is legislative assistant. I did give that right. Your title is legislative assistant, or have you become something else that they give staff instead of raises, like senior legislative assistant? So talk about what your actual day job is for a bit.
No, thank you so much, Rodney. Appreciate that. And thank you all for having me. I'm still a legislative assistant. Titles, can be whatever they want to be. And, I've just chosen to keep this title, even though I've been with the center for 3 years and have been loving that. Especially, being an Ohioan and, getting to work for your home state senator, it's a special opportunity. But I guess the description of what a legislative assistant is, it's generally the advisor for, the member of Congress in this particular area. Being the health legislative assistant, I'm the senator's healthcare specific advisor. So, on a day-to-day, it's consulting him on healthcare policies and making sure that he's abreast of everything that's going on. And more importantly, it's helping strike the balance in order to execute your boss's healthcare agenda, which is formulated, by both his personal beliefs and interests, and also the interests of his constituents. And fundamentally, that's democracy, right, or how it should go. At its core, that means meeting with constituents on a day-to-day basis, hearing from them and hearing what their issues are. But also means, writing legislation and advising the senator on how to vote on legislation or how to proceed through the committee to advance his legislation, or what to co-sponsor, what to push for to advance. Sometimes those overlap, what the constituents are pushing for. Sometimes your boss's interests, may differ from them. And sometimes it's just maybe, just enthusiasm for one issue, for enthusiasm for another. Rodney can attest, the spring time every year is a busy time for legislative staff, because that's the appropriation season fly-in, where constituents will come from all over the country and fly in, obviously, and advocate for increases in NIH funding, or increases in funding for the CDC and what have you. And those are always important. You take those meetings, and that helps you, make the case for your boss to advocate for an increase in appropriations or not. But then also, they'll come and advocate for, Medicare changes and what have you. So it's always evolving and always changing, and you're generally expected to know everything on everything that's under your portfolio, which is impossible, and you do the best you can. And there's never an expectation that you come into the job knowing everything, but you're expected to learn quickly. So that's a little bit about what we do.
Yeah. So I know this from following it, that tonight is an example where you can't turn your eyes from what's going on because the Senate's taking up a bill, and your boss is in the middle of dozens upon dozens of things he's doing in a given day, and he has to depend on you to be able to summarize what's in a bill and what other people are, how other people are voting, and how he should vote. I mean, just as simple as something like that is something you're going to have your day turned upside down, and before 7 o'clock, you're rushing to make sure everything's tucked away.
Yeah, no, that's right. And it got more complicated today because there were some procedural Senate challenges that I don't always fully understand on how, sometimes, a motion to proceed works followed by a motion to table the amendment that's happening. So it was a lot of calling other staff and saying, what does this mean? Do you vote, for a motion to table, you're voting no, which actually means yes. And, we were trying to move a bill forward, but I had to vote no and make sure my boss knew that his no vote meant yes. So it was, a lot of back and forth up until the end of today. And that's not always common. The Senate is a slower moving body compared to the House, but today was a weirdly extraordinary day.
And you having to be on your game all throughout the day because your boss is counting on you to know the answers.
Exactly. Yes.
or find them out if you don't.
Yes.
So let's move to the substance. Let's talk about some of the issues that you work on that are your boss's priorities that you promote for him, that you try to move across the finish line, and some of the areas that you've been spending time. So where would you like to start? I mean, what's some of the things that you that have been working on the health policy side?
Yeah, I think an area that I like to talk about a lot, and I think that it's actually a shared interest that I have with my boss, is actually talking a lot about Medicaid coverage for people with disabilities and long-term care coverage for people with disabilities. It's a pretty bipartisan area that he shares with a lot of, his colleagues, and trying to support people with disabilities and making sure that they have the care that they need on a day-to-day basis to get by and to be active members of their community. And I think that, it's an under-recognized part of Medicaid and the healthcare system that, sorely needs improvement. And at the same time, those are folks that really, need help. And when you think about, what role should the federal government really be playing in our healthcare system, it really should be trying to work for people that can't otherwise take care of themselves. And, people with disabilities, in particular, low income people with disabilities or seniors with disabilities, that's who Medicaid is covering in these instances. And so long-term care, what it means in those particular settings is it's not like the acute care that you would receive if you go to the hospital, or even if you get home health care for, your primary care checkups and what have you. It's really it's the day-to-day to help you get by. It's helping you get dressed. It's helping you drive to the grocery store. It's helping you bathe and toilet and do the basic human essential daily life activities that you really need to do to live a meaningful day. And Medicaid is the largest payer for long-term care in the country. It covers the vast majority of it, and covers it for people like that. And so my boss has worked over the years to support programs like the Money Follows the Person program. He was an early advocate and champion for that. And the Money Follows the Person program, for example, helps move individuals in nursing homes who are receiving what's called institutional long-term care. So those are people that need that care, but are in a more intensive institutional setting, and helping them actually maybe move out of the nursing home and into a home-based setting, or a community-based setting to receive that long-term care. And trying to figure out ways to improve the long-term care infrastructure, because a lot of research has shown that people actually want to receive that care in their homes or with their communities and with their family members, and the outcomes are just as good, if not better. People are much happier in those settings, and it can save money in the long run, and it tends to be good policy. So my boss tends to want to push for ideas like that. Doesn't always get the recognition that maybe everyone should deserve for working on more humanizing policies like that. But they're definitely things that I think deserve to be recognized. And I think at its core, right, it's the fundamentals of what our healthcare system should be doing.
So let's spend a moment on Money Follows the Person, and we can talk about another one here. But on Money Follows the Person, the idea is self-direction. It's giving people people with disabilities the opportunity to have greater self-direction of the supports that are available to them. And is this something that, the goal of this is to give states greater incentive to provide these services at a state level?
Yeah, and it's, Money Follows the Person at its core. What it does is it gives extra money to the states to help, for those who want to move out of the nursing home and to go back into the community. It's called home and community-based services, or home and community-based long-term care. It's giving them additional resources and financing to help make someone go through that transition. And I think you're right. The key thing is also remembering it's only if they want to. Some people like institutional settings. My grandmother is in an institutional setting, and there's a community around that. Especially if the community members that you grew up with in your neighborhood have moved away or passed on, what have you. Your children have moved out. Nursing homes can be a great place for for the elderly and people with disabilities, for a community. And they also offer higher levels of institutional care that maybe is necessary to help someone on a day-to-day basis, especially if you're cognitive issues and dementia, what have you, where it's harder for you to live more independently on your own. But if you want to live in your community, it helps provide resources to help maybe move you out of that. Maybe you are a pretty independent person, but you just have trouble getting dressed in the morning and maybe driving to work or driving to go to the grocery store, what have you. So, helps at least give you that option. I think it's a great thing to push for.
So there are two pieces to that equation, the yin and the yang. You want to provide the supports for the individuals, the people with disabilities who need services, but then you have to have service providers. And so you've also done some work in that space.
Yeah, no, it's, in the provider space is also a key area too, and making sure that we've got the providers available and able to support them. And one area that we actually were working on earlier this year that just like kind of got swept up and passed actually in kind of the initial flurry of COVID related legislation was a bill called the Ensuring Access to Direct Support Professionals Act. A DSP, a direct support professional, those are the general umbrella term that you'll use to describe someone who provides long-term care in a home or community-based setting. And one issue that Medicaid had continued to have over the years was actually that Medicaid wouldn't pay for DSPs actually if a person with disabilities was in the hospital, not necessarily in the nursing home, but in the hospital, which is obviously an acute care setting and is a different care setting. And generally the belief was, why do you need a DSP there if there's a nurse in the hospital? The nurse can help do those daily activities. But for a lot of people with disabilities, in particular, if you're neuroatypical or may have a more difficult time actually advocating on your behalf because of speech impairments, it can be difficult to be your own self-advocate in the hospital. And if you can't advocate for yourself and say, this is why I'm here, this is why I'm hurting, this is what I need to do to get better, this is how I will be able to follow your discharge regimen so that I improve once I'm out of the hospital, you're going to be in the hospital longer, and it's going to make your recovery much worse just because no one's fighting for you and the doctors aren't giving you the best possible care just because they don't know how to help you as best as they could. And so we had proposed this bill back in January, just coincidentally, would strike the restriction on DSPs in the hospital for people with disabilities, just so that they could have that advocate. And then we were trying to push this in January and February, and then March happened and the whole world turned upside down. We had a pandemic, right? And it actually became really essential to get people out of the hospital as quickly as we could, because hospitals were obviously becoming quickly a hotspot for COVID, and you don't want someone who's highly vulnerable, someone with a disability, to be just lingering in the hospital for something that isn't related to COVID, because it's a highly infectious communicable disease. And so the Congress thought it'd be a good idea to include this in what became the CARES Act that passed in the late March. And that got signed into law. It's the fastest bill I've ever written and signed into law. It's a coincidence, and that will never happen again. But it was just generally believed that we need to improve access to providers where possible, generally, whether we're in a pandemic or not, for long-term care. And it was nice to at least see that was included as part of that. And there's, going back to just the general conversation about long-term care providers, there's certainly much more that we'll always need to be doing to improve access there. Long-term care providers generally, whether you're in the community or not, tend to be low-paid professionals. They are typically just above maybe minimum wage, maybe $10 an hour, depending on where you are. And there's unfortunately a lot of data to suggest that, these deaths in long-term care settings, and in particular nursing homes, tend to be counter-cyclical with the economy. And prior to this economic downturn, what we were seeing in Ohio, for example, is you could get a great job at, McDonald's or at, Amazon for $15 an hour, and, doing less intensive work than you'd be doing as a DSP, where you have to lift someone up out of the bathtub or help put clothes on someone. And it's very labor intensive and very demanding, and it's paying you $5 less an hour. And people just don't want to do those jobs if you don't have to, and, or if you don't want to, and you're just looking to get by and make ends meet. And so we've seen over the years that in nursing homes in particular that, deaths can go up in those settings when they're understaffed. And it's tends to be a direct result of compensation and making sure that we've got an appropriate number of staff to take care of people. So there's going to be challenges long-term in making sure that we finance and support these types of providers, but it's a conversation that folks want to continue to have.
And from just the tongue-in-cheek that I would always use to explain that is that, look at the work that the folks in the direct service providers are providing, and how the intensity of what that is as a lifestyle, and know that you can make more as a greeter at Walmart.
Yes.
It's just, but then point out that because so much of the payment structure for both the provision of services and the service providers are Medicaid, that's why this is a public policy issue for you and what you're working on and what your boss is working on, because it's your job. I mean, that's part of the challenge here.
Yeah, and if Medicaid pays little, pays less, doesn't have resources to pay these providers, then they're going to continue to get this low wage. It's not, it's not directly, the reimbursements to pay the doctors come from how many people are paying them, and if everyone's on Medicaid, then it's it's the pay is limited to the payer, which is Medicaid there.
Right. And again, sort of looking a little ahead, that it also creates pressure on you, Congress generally, knowing that come January, as states go into session and they're looking at their budgets and looking at the economic impact they've been feeling, they're going to look at how much they pay providers and how hard that makes everything.
Yeah, that's where states will cut funding. States have to balance their budgets. They're obviously budgets and economies were in a free fall in March and April, and when Ohio was an exception, and when when you look where to cut things, you're not going to cut access to a service. You're not going to say no more DSP coverage in the state of Ohio or in Virginia or where have you, but you'll lower the reimbursement for each of those services so that service access is maintained, and in the short run maybe it holds up and you can continue to see those providers, but in the long run it can discourage folks to want to go into those professions if they're not going to get paid a wage that they deem is fair.
Right. Which, for the purposes of folks who are thinking about the concept of health policy and how pervasive it is, what you think is a simple provider and beneficiary relationship is extraordinarily sensitive to the financing decisions made on the governmental side, the health policy side, from either the federal or the state level. They're never divorced from that reality, and that's part of how you are. You recognize that, and you're trying to solve it, which is the impressive thing that you're doing.
Trying.
So let's transition a bit to talk about some of the political side, the process side, what it's like to then try to navigate bills through. And you talked about one that went through in a flash for a number of reasons, but there are other things that you do that are how you work the process to cause outcomes. And so I think one of the ones that we knocked around talking about was talking about the 340B drug discount program and some of the work you've done recently, just producing a letter to talk about that. And so, talk about what you go through in trying to organize something like that.
Yeah. So to probably describe what we went through, I probably should explain what the 340B program is really quick. Established in 1992. The 340B program, just explicitly what it's called because it's Section 340B of the Public Health Service Act. It requires drug manufacturers to give discounted rates on their prescription drugs to certain what are called covered entities. Those are some of your high need safety net hospitals. They're your community health centers. They're your Ryan White clinics, which support people with HIV. It's your rural hospitals. It's your children's hospitals. So it's a defined set program. It's not substantially large. It's meaningful for the hospitals, and some of the manufacturers will feel the pinch from time to time from the program. But it generally is about maybe 5% total of all drug spending in the U.S. So it's compared to all spending, it's not huge, but different manufacturers will bear that brunt in different ways based on what drugs they have. But so it obviously sets up a nice paradigm where on the one side you've got the drug manufacturers who are not pleased that they have to give out these discounts, and then you've got the hospitals who and covered entities who certainly love this program. They are getting discounts on these drugs, and more importantly, what they do with these drugs is that they will buy the drugs at a low rate, the 340B rate, and they can sell it at the normal rate back to patients. And then they're able to use that excess revenue that they get from the drug and apply it to community benefits. So, if you're a struggling rural hospital, for example, you can use that basically to keep you afloat and keep you out of the red. For a lot of community health centers in Ohio, they've been able to use 340B to expand their access to naloxone and other substance use disorder treatments so that we could help better fight the opioid epidemic. And it's a pretty flexible program for those covered entities because it's just added cash, to be honest. So, there was an interesting dynamic that got set up about a month ago. It happened really suddenly where some of the manufacturers started to take actions to try to limit how they were going to be giving these discounts and trying to limit the total amounts they're giving by trying to cut off some of the pharmacies that they sell these drugs at, and which obviously would have limited the cash to the covered entities and upset the covered entities and the hospitals. So my boss was in a position where he's traditionally supported this program. He wants to help the covered entities, but there were some good points being raised by the manufacturers, and he had to figure out how he was going to thread this needle to try to, support the hospitals, but not overwhelmingly upset the manufacturers. And we had to go through a process where, we traditionally on 340B issues work on a bipartisan nature with 5 other members, 2 other Republicans and 3 other Democrats, just to keep things as like a neat group. And we're actually really the only group that actually does things on 340B in a bipartisan basis, because every other group that ever exists in Congress right now to try to address these things tends to be pretty partisan in their nature and how they respond to the program. And we try to just focus on what's the bare minimum common sense way to move forward, be constructive in our thoughts and critiques about the program, but also still maintaining the general premise and integrity of the program. So we ended up writing a letter to HRSA, which is the agency that oversees the program, telling HRSA to push back on the manufacturers and to say that the actions that they were taking were, in our opinion, illegal and they violated the statute. It was a pretty strong statement from our bosses, to be honest, and it wasn't a decision that they really took lightly, because they care deeply about these covered entities, and these covered entities are also seeing drops in their revenue as well because of the pandemic, where they've had to suspend services, and just generally didn't feel it was necessarily appropriate given the times that we're in right now. But they had to obviously navigate, how do you support manufacturers and drug manufacturers who may be based in your state and who use this revenue to be, this revenue to go back into R&D and, to be funding the development of a COVID vaccine. And how do you balance that? And I think when we looked at things, we said, we hear the manufacturers' concerns in this program and, want to respect them as they go through this R&D process for COVID. But at the same time, it's not a big program to them, but it is meaningful to our hospitals and our Ohio stakeholders. And it's kind of how we chose to respond the way we did.
So for maybe some of the listeners on our conversation here, they might be listening to this going, okay, so you wrote a letter. Now, I know better, but I'll let you jump in. Why should a federal agency care if you got together with a number of senators and wrote a letter?
So there's a few things. One is, at a minimum, a letter from a member of Congress to any administration almost always has to warrant a response and requires them to recognize whatever you're writing about and force them to respond and say, they have to either go on the record and say, yes, this is an issue, we agree with you, or no, this is an issue and here's why we are going to disagree with you and go forward as is. So at minimum, it gets you on the record and forces them to get that position. If they don't respond, it actually gets much worse and members will get very upset, and that can lead to, checks and balances, hopefully. But, additionally, on top of that, no administration really likes to be put on blast, and they don't like the media attention around, around being called out for an action that folks may or may not agree with. Other times, if you write a letter and you're just saying, we support what you did, it can give them the cover to say, oh, well, Congress backs us here, so let's keep on going in what we're doing. And it helps generate a narrative and immediate dialogue around this. The next day that we wrote the letter, there was in Politico, saying my boss and others were leading the charge to support the 340B program. So the narrative was out there, and, the folks at HRSA hopefully, read Politico like the rest of us, and they get to see that even if they hadn't seen the letter right away. So it gives them a little teaser for what was to come.
And there was also a letter from the House of Representatives, and it had
a
lot of people on it.
Yeah, that was I thought a rare moment where the House actually came together bipartisanly for this too. And I think that showed how concerned people were about some of the action that were taken.
North of 240, I recall, something crazy like that.
Yeah.
Yeah, the majority of the House of Representatives. And the signal to an agency is, if you got the majority of the House and a huge chunk in the Senate, maybe you ought to can reconsider the trip you're on and maybe turn and go back the other direction. But
Yeah.
it starts with you taking this action and your job and what you do. I mean, that's how it starts. It's with somebody like you doing the grunt work of putting together the letters, seeking the people to sign it. At least now you don't have to run around office to office actually physically getting the signatures. I'm old enough for that. But
That used to be horrible. That
oh,
was because you would go in alphabetical order, whatever order they signed up on, but their offices are not all in the order by which you did it. So you just go back and forth between all the buildings and different floors. You'd have to like carve out a whole day. It was horrible.
and just to say out loud, for those of you in the audience who envision yourself as an intern, just telling you what the job may entail. Oh,
That's what it entails, but you curse yourself when you get enough signatures on your letter because you don't have enough interns to collect it all in one day. So then you have to go and do it too. So you'll kind of like hand out pages for everyone, go, okay, we got 6 pages of signatures, but like I've got to take one of the pages. It's horrible, but
yep.
you do what you got to do. But at least in COVID, you can just e-sign and go with it.
Yeah. So another process conversation, we don't need to get deep into the policy of it, but it's interesting to talk about the process behind the Senate Finance Committee's drug pricing bill and talk about the pressures that go on within the Senate, where you have a chairman and a ranking member who are both trying to represent their members as best they can, who are dealing with their own leaderships, the Senate Majority Leader, the Senate Minority Leader, who they're putting pressure on it, and how that affects legislative outcomes and how it makes specifically your job, that much more difficult because of the way processes work or don't work.
Yeah, that was this process. I don't know if you said this happened last summer, or at least really came to a head last summer. It was interesting, and I think so. We started the new Congress the beginning of January of 19, and Rodney's former boss, Chuck Grassley, was coming back into chairmanship for the Finance Committee, and everyone knew from his past experience, he's very passionate about curbing drug pricing increases and getting drug prices down. And we knew that was going to be probably, we thought at the time that was going to be the high water mark of the Finance Committee. We didn't expect a pandemic to happen, but we knew drug pricing was coming. And so folks started getting ready and trying to figure out what their boss's respective priorities would be in a package to address drug prices. I worked, for example, on one piece of the package that ended up coming together to deal with weird instances actually where injectable drugs that doctors have in their doctor's offices that are, have way too much excess drugs, and that patients pay for the drugs in excess and just get thrown away because the manufacturers are making large drug vials intentionally to make waste and to claw back money with that. And we would have saved Medicare $8 billion if it passed. So it was not insignificant. But so people were coming up with ideas like that and how to reduce drug costs and reduce waste where possible. But things were coming together hopefully bipartisanly through January through April and May, and then things started to get a little weird and funky, and people started feeling that something wasn't right, and conversations were starting to stall. And we couldn't tell necessarily at the time what was happening. Members were a little confused. Why weren't we making more advances on drug pricing? We'd been told, oh, we'll pass something in May. May rolls around. We're told we're still working on the bill. We're still ironing out details with, this was coming from the chairman's office and saying we're working out details with the ranking member, who's the lead Democrat. And then ideas started floating out that there were ideas around, penalties for drug manufacturers that raise their drug prices too fast above the rate of inflation, penalties around, launch price increases, initial launch prices that were set too high. These were coming from the Democrats, and we're being told to Republicans that these are our conditions, that these have to be in a package, or else we won't agree to a bipartisan bill. And obviously bipartisanship is how you get stuff done. And we needed to make sure that we stayed bipartisan. So there started to get a lot of pressure on Republicans on the Republican side of the dais in terms of what to do about this package. We were hearing all these ideas that Republicans didn't really feel comfortable with. They really strongly opposed ideas like a launch price cap where, drugs could never be set above a certain price. There were a lot of concerns about an inflationary penalty, penalizing the drug company for raising the price of their drug too quickly. And a lot of that, as I mentioned earlier, comes back to the fact that there was legitimate concern that if you reduce too much money too quickly, or even just in general from drug manufacturers and their drug pricing schemas, it will cut investments in R&D and could jeopardize long-term, advances in finding cures. And for example, when the CBO scored the House's bill to establish, Medicare's ability to set drug prices across the country, the trillions of dollars or the $500 billion that the bill would have saved, the CBO said that would have cut at least, 10 new drugs over the next 10 years. And that means, those are the riskiest types of drugs that manufacturers aren't going to invest in now. They'd rather invest in a safer drug like a cancer drug, which are much easier to develop and manufacture. And they're just going to cut spending on R&D for Alzheimer's drugs and things like that. And that was really concerning to a lot of members. And so we had to grapple with how far do we want to go in terms of fighting for bipartisanship, but also not going against principles that the members had where they wanted to support, protecting R&D investments for the manufacturers. And so things started to really come ahead in July. And unfortunately, the way it played out was the chairman made a decision that he was going to accept a number of the asks from the ranking member. He didn't accept all of them. He accepted most of them in exchange for all the Democrats agreeing to vote for the package. And then he told his Republican members, this is the package, take it or leave it. And a majority of the Republicans on the committee did not vote for the bill. 5 members, including the chairman on the Republican side, did vote for the bill. So 5 Republicans plus, the 12 Democrats, that pushed across the finish line because it was only a majority of +1. So they were able to get out of the committee. But, in a Republican Senate, when a majority of the Republicans on the committee don't vote for a bill, it spelled the death of the bill. And we've never passed drug pricing now with this Congress as a result.
So thinking of it this way, and goodness knows I went through enough of these myself, it is that there has to be both political consensus and policy consensus. And no matter how much you try to get to policy consensus, if you don't have political consensus, you can't get things done. And that, how do you, as just, a staffer, how do you get zen with the reality that occasionally things are just going to be beyond your control?
It's a lot of cognitive dissonance where you just convince yourself that you've done the right thing. I think both the examples we just discussed, 340B and this, unintentionally are about drug manufacturers, but a lot of it was about, recognizing that they play a really integral role in the healthcare system, but at the same time, sometimes concessions from both parties are sometimes necessary in order to move things forward in a bipartisan or policy-based manner. And what compromise can we all give on to make things happen? And, on 340B, I think folks felt inclined to go really strongly one way over the other. On drug pricing, folks were really split, and it was hard to really ever find a solution there. And we still really haven't. And it's, all the stakeholders that are in the game have legitimate arguments and interests, and you want to make sure that you're balancing them all favorably and fairly. And sometimes it's just easier than others. And sometimes it's much easier to say, you're right, you're wrong, but sometimes it doesn't always go that way.
So before we go to Q&A, I teased this at the beginning, and I think, again, for students, it's valuable to understand your pathway. I mean, they can talk to me all they want, but hey, when I was there at Roanoke, I still had a typewriter, right? So listening to an old guy is not nearly as valuable as listening to you. Talk about how you made it to where you are today, and what was sort of your pathway to becoming a dazzling legislative assistant for a United States senator.
Yeah, so it was a lot of what I thought at the time was luck. I started out this path where I got my MPH from GW, but I was actually part of it's a BS MPH program. So it was a combined 3 years of bachelor's in science and public health, and then 2 additional years of my master's in public health, and just kind of saved time and money in the process. And it was a great investment, although it was a lot of work to condense 4 years into 3 and still do everything in 5. But so I was in my 4th year, which was technically my first year of grad school, and I was about to finish up. I just finished up my first semester-ish at that time. And I was trying to figure out, what do I really want to do, and what do I want to do with this degree? And at the time, I thought it was a novelty that I was in an online class, but I was in an online class in part because I had to take some overlapping classes just to make sure I got all of the necessary requirements done for both degrees at the same time. But I was in this online class for my grad school program, and one of the students in there, we were just talking, and she said, what do you want to do, Seth? And I was like, truthfully, I have no idea. And she's like, well, do you want to work in policy? And I was like, yes, I do. I don't know what that means. And she's like, let me connect you to my friend. Just getting to know what he's doing. Maybe he's got a job available for you. We can go from there. That friend was accidentally Rodney, which was very serendipitous. Interviewed with you. It was half informational, half, for a job that you had available. It didn't work for timing reasons. Like, my schedule didn't work, but also by the grace of God, you were like, I have a much better idea for you. And you referred me on to my first job on the Hill, which ended up being with Dr. Burgess. I started off as a legislative fellow in his office. And so did that for about 8-9 months, where I was then able to get promoted and to be a legislative assistant for Dr. Burgess. I skipped a lot of steps actually in that process, to be honest. It was a little atypical to go from, have your first Hill job really be a legislative assistant, but I had at that point, I was finishing up my MPH. I was almost done with my MPH. And on top of it, Dr. Burgess takes his legislative fellow positions really seriously. It's more like a legislative assistant junior light position, where you do all of the work as a legislative assistant, but are just dramatically underpaid because they recognize you're trying to start out and usually are in school at that time. So I got my first start on the Hill through that. And then I was the legislative assistant for Dr. Burgess through all of health reform in 2017, which was fun and stressful and just a thrilling time, and can't wait to do that next year. But as that was winding down, a woman named Sarah, who later became my predecessor in this current job, she was also an alumna to Dr. Burgess's office, had done the MPH program, not the BS MPH, but just the MPH program at GW as well. So we had known each other for years. She was from Cleveland, I was from Cincinnati. And it was kind of we did all the same steps the whole way through. But when she had left Dr. Burgess's office, she went to Senator Portman's office and basically got a hold of her. And she was like, I have a deputy position in my office if you want to join this office. And I was like, sure. Honestly, I can't say no to working for my home state senator. I then found out I was bamboozled and that she was leaving the job 2 weeks after I said yes, and that I would be moving up into the role. So I always tell people that they were just making sure I had a pulse and that I was competent for the job, and that she gave her 2 weeks notice after my 2 weeks in on the job, and then I moved up into that position. So it all happened really quick. A lot of it was luck. I didn't really, I didn't know Rodney at the get-go. I knew Sarah through connections, but as I look back on it now, what I thought was luck was a lot of really kind of my willingness to network and to meet people and to make connections. And I was always very self-conscious and a little uncomfortable at first trying to make those connections because I didn't realize that was how things work. And now, as a result, I'm very always open and eager to meet with people and to try to help people out where I can there. I don't always know if jobs are always available, but I having a connection is always indispensable, because I knew Sarah through GW and through, my Burgess connections. And as a result, when the time became available that she was getting ready to leave, she knew me off the top of her head, and she could say, I know an Ohioan that's got healthcare experience. He has got the exact same experience as I've got. So he's got to be good. And, it worked. So, I've learned that, connections were the luck that I thought kind of existed there the whole time.
But I will cap that by pointing out, connections can get you indoors, but you still have to produce once you get in the door, and you are where you are because you have produced. And so you've earned every bit of where you are, young man. We've hit the fourth quarter, and Brian and Shannon, I think this is when we're supposed to bring you back in and see what our friends are have to ask us along the way, and totally open to anything except for my roommate, Stuart Sullivan, who's already on the board here. I'm looking forward to this.
So I'm actually going to tee us off with another question, and then we'll get to Stuart's questions. So you have a minute to think about those, Rodney. So Seth, you really set us up perfectly, because a lot of the students who are watching are either policy students or public health students. And so one of the questions we have is, how much do policy folks work with public health experts? And vice versa, how do public health experts get ideas to policy folks?
Yeah, that's a great question. I think one of the greatest privileges of the job, besides getting to, work with an elected official on a daily basis, is a little bit of an ego boosting moment where you can email whoever you want and say, hi, I work for Senator so-and-so, I would love to talk to you. And they can be, be the head of their field. They can just be, down to, the DSP that I mentioned earlier. And they are eager to talk to you because they know that you have that an elected official is going to go to you for advice, and they want to have that opportunity to talk to you so that they can build a case why their vision and view for ABC is the right way to go on things. So we work with a lot of, public health officials on things. I just emailed the CDC this morning asking a number of questions about improving reporting requirements for certain, conditions and things like that. And they're going to want to respond to me because I've asked them for their advice on what they would like to do on the congressional legislative side of things. So they're going to be eager to respond back to me and say, yes, of course, this is what we would recommend. And, try to reach out to, we work with stakeholder groups a lot, trade associations, whether that's, weirdly, the first one I thought of is like ACOG, for example. ACOG is, the American College for Obstetricians and Gynecologists. Every provider group has their own trade association that they work with, and you work with them a lot because it's easier to talk to a policy expert at the trade association versus having to go and reach out to, every single OB-GYN in your state to get their perspective. So you work with them a lot, you reach out to them, and usually if you reach out to those groups, they're happy to respond to you because they would rather have their fingerprints and their feedback involved in the policy making process versus not, and vice versa. I think the other side of that question is, how often do they reach out to you? All the time, frequently. I've watched my inbox tick up as we've gone through this, and just as much as they're happy to respond to you, they're also just as eager just to send a proactive email to you saying, hey, want to give you my 2 cents on what's going on here. And we have a policy in our office where we always respond to, Ohioans and constituents. We always do our best to make sure that all Ohioans get their time with us and make sure that they're heard. Generally, it's my personal policy to respond to every email I get. I do my best. I sometimes miss the first email that comes through, but I usually am pretty good at responding to their follow-up. Hey, did you miss my email? So folks usually know how to reach us, and I try to make myself as available as possible to anyone that's got an idea, because I don't claim to be an expert. I just kind of funnel the expert's ideas to my boss.
Right. No, this is fantastic. And your story is great for our students to hear. And I've been remiss. Thank you both so much for getting this series of talks started. This is a wonderful start, and your answer is terrific, again, for all of us to hear how these different constituencies interact with each other. Brian, I'll turn it over to you for a minute.
Yeah. Well, Rodney, I think you can see Stuart's questions. Do you want to, do both of you want to jump in on that?
So given the political nature of these questions, Seth, I'll do the honors here, so not to get you in trouble here on a live feed. Please distinguish between Medicare for All and Obamacare. So I'll do that one right off the bat. The Affordable Care Act, Obamacare, intended to try to create a structure that would allow the private market to provide healthcare insurance for the people who are uninsured in circa 2009-10, with the idea being that private competition would then work together to cover people while trying to keep costs low. What we see with Medicare for All is an ongoing reaction to the fact that costs remain out of control, and that the solution is to put everybody in a more government structure where government controls both the inputs and outputs, and ultimately something called Medicare for All. What do you expect to happen in healthcare space funding should Democrats control the White House and both houses of Congress following the election? I would take very seriously ideas like the public option, which again, work from the idea that we need to have something out there that provides an option where the costs are controlled with greater incentives than you have through the private market. So public option will have to find some way to cause participation and control prices. And that I think you take that very seriously if the Democrats are in charge, that's something they would work to. Is it okay if I took that one for you, Seth?
I was thrilled. Thank you.
You're welcome.
Okay, Seth, so we have another question here for you. What is the most frustrating part of your position?
Yeah, that's a great question. I'm gonna probably quote my mom, actually, just because talk to my mom every day when I'm frustrated about my job generally. And you know, it's hard to always explain, you know, generally what your job is on a day-to-day basis, because there really isn't a day-to-day for my job. And I love that part actually about it. But I was explaining it to my mom once, and she was like, wow, it sounds like you're always, you know, hurrying up to wait. And I thought that was a really good description of it. And it's a lot of fast moving actions to then just sit and do nothing, and a lot of effort to write a bill that you're writing really, really quickly because you want to get it out there, and you're working with all the stakeholders and you're saying, this is so important, I have to do this right now. And you introduce it, and then that bill will sit out there for 2 years, and it will collect dust and it won't do anything. And you're like, I put all of this work into this, and it's going to be years before I see progress there. And you know, I think it's a good thing that, you know, legislating is methodical, and it requires, you know, bipartisan consent, and, you know, for folks to want to work collaboratively and move things together, and that, you know, everyone's fingerprints will be on a bill, and that, you know, I think it's a good testament to legislation. And I always used to say that, like, when you're working on a bill and you're fine tuning it more and more, ironically, actually, the more frustrated you get with the process, the more tired and done with a bill that you are at any point in time, kind of means you're getting closer to it being done. Because if you're still excited and enjoying what you're doing on that moment, you clearly haven't worked on this bill long enough, and just give it more time and that joy will get crushed there. But it's a lot of frustration just getting things done. But you know, at the same time, that's what you also like about your job. So it's two sides of the same coin, but it's a lot of, you know, hurrying up to wait.
Well, for the record, what you just described is also academic publishing. So,
Yes, indeed.
just for the audience.
Yes, it is.
Shannon, do you want to take the next?
Sure. We have a couple of questions from Emily Odell, who's a current student at the college. And Seth, these are for you. She'd like for you to elaborate more on the bipartisan communication scene with 340B, and then related, you know, how has bipartisanship further shaped the conversation on drug pricing?
Yeah, that's a great question. At its core, with bipartisan communication, a lot of it comes down to just like, are you a nice person? Are you friends with the other staff? You know, it really is a testament to that. You know, honey collects more flies than vinegar, or whatever that saying is. You know, my boss has always worked in this bipartisan unofficial gang, if you will, on 340B. And it's actually how I made a lot of my initial friends in the Senate. You know, the two other Republicans on that group, and then the three other then. And then in 2018, actually, one of the Democrat members lost his reelection, and so we became lopsided at 5. And 340B kind of went quiet for 2019, so we weren't really doing a lot then. We didn't need to fill that role. And then 2020 rolled around, and this came up again, and we were like, okay, well, we should loop in at least one other Democrat to keep this balanced and bipartisan. And the new Democrat that we did include, and take this for what it is, obviously the member was genuinely interested in being involved in the process, but it started off with us texting the staffer being like, hey, do you want to do this with us? Like, we're all just like, it was a good friend of mine. We texted them and they were like, yeah, let me ask my boss. Boss was thrilled. Thanks for asking me. But we thought of the member in question first because we like their staffer, and I think that's just kind of like good. It's just, sometimes that's how those things play out. So that's how that really started. And, with that 340B letter, there was a lot of back and forth, behind the scenes and writing the letter, some strong opinions on what one word should mean over another. That was a lot of debate, and I won't go into that specifically and what we were debating there, but, we agreed on certain parts. Some of the Republicans had strong positions on one part, Democrats had another position on another part. We both agreed to have parts of both in order to let the letter go forward. And, even though we're friends, we'll have differing beliefs on what the letter should read or, what have you. But we kind of just, we were all moving together collectively, and we all wanted to reach a conclusion or a goal, of advancing this letter. So we were willing to compromise. And, there's certain instances where the outcome is so important to you that you're willing to make that goal into compromise. As you've seen in some other legislation, like a lot of the COVID legislation, folks want to reach a compromise, like in the CARES Act, and they were willing to get there because of the daunting nature we were approaching right in March as the pandemic was starting. Similar with this letter, it's a much smaller scale, but we wanted to reach this outcome where we were responding on behalf of our covered entities, and we're willing to make concessions to make the other one happy so that the letter would move. And we made those concessions, they made those concessions, and that's how that worked. But being friends with each other also helped keep it civil, and people weren't mad at each other in that process. In the drug pricing side of things, bipartisanship worked for a good period of it. And then also, it's hard because both sides wanted a lot, and both sides weren't always necessarily willing to give on, to make concessions. And they were, everyone's got a bright red line on certain things about what they believe. And it kind of ended up that the red lines for those issues were just a little too far for people to reach. Maybe, to be honest, folks didn't want to move their red lines further. They weren't willing to do it just because of political interest in not doing so. Maybe it was a philosophical interest. It differed for every member that voted the way they did, or who's subsequently blocked the drug pricing bill from moving forward. Both Democrats and Republicans have since blocked that effort from the committee product. They blocked that from moving forward. So Republicans and Democrats, have interest in still moving drug pricing forward, just maybe not that vision. And, it's how badly do they want it, and how badly do they want to compromise? And hopefully one day we'll figure out a compromise on drug pricing. Just in 2019, folks weren't ready.
Okay, well, maybe we have time for one more question.
One question there is,
yeah, I can do one more. Yeah,
wheelhouse. So I think you throw that one out there if you could.
Let's see. Oh, yeah, the last question. Yeah, here we go. So can you describe a little bit more about how the drug pricing program kind of combats the opioid crisis, and maybe talk about the role, the determinants, how that affects opioid addiction?
Because
sure.
Your boss is one of the leaders in this space.
Yeah, no, I appreciate that. I mean, put that plug out there briefly, because I think he would be upset if I didn't talk about, his efforts to address opioid addiction. That's it's a much more higher profile thing that my boss works on typically, and actually why I started off talking about long-term care, just because it's something that I think he's generally under-recognized in his efforts there. But, my boss has been since the 1980s, before he was in Congress, then in the 90s when he was elected to the House, he was a leader in fighting, drug addiction in the Cincinnati community in the 80s. He then helped establish the Drug-Free Communities program in the 90s when he was in the House, has then helped further champion that through, the early 2000s. And then, through his time in the Senate from 2010 onwards, when he was elected in the Senate, he had major legislative advances in addressing the opioid crisis and drug addiction. 2016, his bill CARA with the Comprehensive Addiction and Recovery Act was signed into law in 2016. That was the first really major monumental piece of addiction policy that we really ever had in this country, that treated addiction as a medical condition, that said there are medical ways to be responding to this, whether that's through medication-assisted therapy or just finding ways to get people into treatment and not treating it as a moral failure and, just abstinence only for drug addiction. And I think that he's really proud of the work he's done there. Obviously, it's his decades of involvement, but unfortunately also it's Ohio's unfortunate challenges with the opioid crisis over the past, decade or so. Unfortunately, year after year, record deaths of drug overdoses. We've kind of seen that plateauing a little bit over the past few years, but in just this year alone, it's skyrocketing due to isolation and lockdowns and unemployment and social isolation and just despair generally. And so he's very upset and concerned again. And so, he's doing a lot to try to figure out how to respond to that crisis, and is always working bipartisanly with his colleagues to do that. His CARA legislation in 2016 he led that with Senator Sheldon Whitehouse from Rhode Island. We work a lot with our colleague from Ohio, Senator Brown, who's a Democrat. In 2018, he led on an initiative to lift what's called the IMD exclusion, which is a Medicaid provision that at the time capped how many inpatient beds a facility could have for Medicaid to pay for it. It was really limiting inpatient rehab care, which was essential to care. And we worked with Dick Durbin from Illinois on that. So he's pushed a lot in these issues, but specifically to the 340B program, which is part of the question that was asked, at its core, it's really addiction and recovery services. Is really how do you expand access to care. Talked about the IMD exclusion as one way to expand access to care, but a big way that 340B has helped addiction recovery in Ohio is, if you're familiar with a drug called naloxone, that is a overdose reversal drug. It is key to first responders' abilities to respond to opioid overdoses. And if you get someone in time while they are in the midst of overdosing, and you give them naloxone, it helps revitalize their lung capacity, and they start breathing again, and it saves lives, and it's an incredible drug. And the community health centers really started to redirect a lot of their resources a few years ago, in particular thanks to the 340B program, by steering that towards expanding access to naloxone, making sure that their providers had it, that pharmacies had it, so that loved ones could go buy naloxone and make sure that they had it on hand in case their family members or neighbors overdosed, or that sometimes, unfortunately, you just see someone on the street who would overdose, and encouraging people to go buy the naloxone through some giveaway programs of naloxone to their community, out in their community, so that you can use it if you need to, and things like that. And so it's a flexible program where they could expand access to naloxone. They were able to, a number of them were able to expand access to what's called medication-assisted therapy. That's drugs like buprenorphine, which you can give to someone who is addicted to opioids, and it can help, block a lot of the neurotransmitters associated with that addiction and help get them off the drug, so that they are not putting themselves at risk, and expanding access to providers to pay for that, who can prescribe it, because there's certain requirements to prescribing drugs like buprenorphine. So it's the 340B program really was helpful there, especially in more low-income communities, more socially isolated communities, like our rural communities, our underserved communities. And generally, I think we were independently supportive of the 340B program, but I think seeing the work that it's done for the opioid epidemic has really kind of changed, or has increased our emphasis for the program.
Okay. Well, thank you, Seth and Rodney, for this really great conversation. Thanks so much for joining us tonight, and thanks to everyone who joined us in the virtual audience for tonight's NOKELive from DC. We invite you to join us for upcoming NOKELive events. We're hosting several of them in October. For more information, visit roanoke.edu/alumni and visit the Alumni Hub. There you can find links to upcoming and past NOKELive events. And also please check out the Roanoke College main webpage for other online events. So take care, everyone, and stay well.
Thank you again.